My name is Lara Wilson. Thank you so much to Sylvia for getting us started with an overview of what's happening with the various drug epidemics in the US. We're going to zoom in on the opioid epidemic and one particular response to it, which is supervised injection facilities. And before we get started talking about this, I want you to just have in mind throughout this talk a patient of yours who might be actively dealing with injection drug use, for whom, of course, we always hope that people are able to stop. But if they're not in a place to be stopping right now, if you could design a dream intervention, what outcomes you would want for that patient of yours. To begin, I have no disclosures. The goals of this talk are to review the current evidence on supervised injection facilities and then look at various models. Said a little bit differently, I first want to take us through what accessing a SIF, supervised injection facility, which is sometimes referred to as a SIF, looks like, and then look at how SIFs impact their clients and communities, and finally look at the current status of legislation and SIF efforts in the US. So going back a little bit to Dr. Peterson-Perry's talk, the current status of the opioid epidemic in the US, to give us some perspective, this was back in 2016 and it has grown since then. There were around 60,000 opioid deaths per year in this country, which was about 10,000 more than peak car crash deaths, 15,000 more than peak HIV deaths back in 1995, and about 50% or 20,000 more than peak gun deaths back in 1993. So this is kind of an epidemic among epidemics. If we look by race, this epidemic is largely thought of as a white predominant epidemic, which is true if we look at the numbers. Here we can see, just checking. So here we can see the trends by race between 2000 and 2019. As you can see, white people make up a majority of the deaths from opioids. But if we actually compare the 2019 numbers to the 2000 numbers, there's been a 490% increase among whites and a 653% increase among Blacks and 602% increase among Hispanics. So there's actually been greater increases among other races. If we look at per capita numbers, which unfortunately I don't have that graph in here right now, it remains highest per capita among white people in this country, but the rate for Black people is increasing and is not benefiting from that kind of plateau that we're seeing among white people over the last few years. So one other point on this is that obviously we can think about, when we think about the opioid epidemic, we often think about its main precedent, which is the crack epidemic, which was responded to with criminalization and significant mass incarceration. And when we look at this epidemic, we have the experience of that previous epidemic that we've been able to learn from. And I think also the different racial demographics contribute to much more of a harm reduction response to this pandemic, to this epidemic. Why are we thinking and talking about this so much right now? The heroin epidemic, as Dr. Peterson-Perry talked about, has been pretty stable for a long time, but we're really seeing increase in opioid deaths related to the use of fentanyl, which took off around 2015 and just continues to increase. And that has implications for treatment in a few ways that we'll talk about down the line. To just get language in place before we really dive in, supervised injection facilities are medically supervised hygienic locations to consume intravenous drugs illicit drugs intravenously. There's other names for this. You can say supervised or safe injection or consumption. Consumption obviously allowing other forms of ingestion, and facilities or sites. They're also sometimes referred to as drug consumption rooms. Sometimes the descriptions will describe recreational drug use, which of course is sometimes how drugs are being used, but we also know that in the vast majority of situations, they're being used to stave off withdrawal symptoms. And so I prefer not to use that term. Let's now take a quick video tour to see what it looks like to actually access one safe injection facility. This is the Insight facility in Vancouver, which is our closest, the closest safe injection facility to Seattle. And I am going to just transfer over screens really quickly. We have to start with a quick little commercial, and I apologize about that. Oh, look at that. We're able to go ahead without it. Are people able to? Sorry about this. Okay. So I'm going to go back to the beginning really quick because I can hear that you guys aren't able to hear. So this is walking into the safe injection facility inside in Vancouver. That's the front desk where people are able to pick up their kits with their safe injection supplies and do basic intake. They then enter, this is the waiting area where if there's a line, they wait until one of the injection seats is available. Here's a little sanitation station. People often don't have great access to basic hygiene, and so they try to provide that up front. And then here's the area where drugs are actually consumed. So everybody has a booth. Those booths don't have backs, and there's staff that's able to sit on the other side and monitor them during use. This is where other employees are able to help monitor and also answer any questions that might come up. This is a medical room that they have available in case emergent medical situations arise. And then once people feel that they would like to move on, this is the chill out room area. So this is after use where people can hang out for whatever period of time they would like to. There's also offices for other resources that are available to them before they take off out through the back door. So gonna switch back over. There we go. So there we go. So like I said, when they first enter a facility, there's an intake process where they get education on safe needle use. At a highly resourced SIF, they'll also get a needs assessment, and they'll be able to collect their kit of clean supplies. You can see the kind of building blocks for that in the picture on the right. Once they're able to get to sit at one of those booths, their staff were able to observe their habits and make sure that they are using safe injection practices. And then they're also available in case of overdose. With fentanyl being on the rise, this is an especially important piece because obviously overdose is more common. People are being intermittently exposed, and when they are exposed, it can require more than 1 or 2 doses of Narcan, which might not be available outside of a medical facility. And then once they are done using in that kind of chill out space, depending on the resources available at the SIF, there can be crisis management, there can be shelter referrals, there can be counseling available. There's certainly often encouragement to seek treatment, and sometimes that treatment is even available on site. There's no regulation on how long people need to hang out after use to ensure that there's not an overdose occurring. Peak dose of opiates is 5 to 10 minutes after IV injection and 30 to 40 minutes after intramuscular injection. But overdoses can occur up to 90 minutes after use. We don't know how long, we don't have any data on how long people are typically spending at SIFs after use, but we do know that these chill out rooms have become kind of a social space for a lot of people, which for the medical community is a really great thing. So here is looking at some client experiences, and I'll give you guys just a few minutes to read through these. These are people speaking to how they feel about accessing safe injection facilities. And I think this is a nice point to think about your patient who might be dealing with active use, and to imagine if they said something like this to you, how you might feel about it. I think the one that really sticks out to me is the last one that says it's like a home away from home. It's like a support center for junkies. The staff listen to you, they actually hear you and feel what you're going through. And I think an increasingly large number of people are coming there to get acknowledged. And largely related to the kind of word on the street about what these injection facilities do, surveys about whether active injection drug users in the US report really high rates of willingness to use these in the high 70s to low 80s range. Thinking of the different models that are out there, we're mainly going to be talking about integrated models. So these are the most highly resourced models that they're the most common, they're the most well-known, they have the most robust support services. They're able to offer extra services on site and referrals. They can be a challenging atmosphere for people who are in recovery and not planning continued use. There's also specialized, which focus just on safe use, so really are there to monitor and respond to any overdose occurrences. And then there's mobile, which is essentially specialized, the specialized model in a mobile form. So in something like a van, they typically have lower capacity, and they're much better for areas that have more disseminated epidemics and concentrated epidemics. On the right, we've got a graph of the different roles that are employed at different safe injection facilities. This is a survey of European safe injection facilities. As you can see, most of them, 4 out of 5, about 80% have nurses and social workers employed. About half have medical doctors, and about 30% have either a psychiatrist or a psychologist on staff. Only about 10% are able to have case managers. And I would also highlight about 1 in 4 have peers who are employed by the safe injection facility. So they actually provide a little bit of a ladder towards formal employment. Turning to the actual impacts of safe injection facilities, the number one that's typically talked about when we're considering these is reducing overdose deaths, and they're extremely successful. The data is really impressive on this one. So there have been no reported overdose deaths at safe injection facilities. At least at the Vancouver site, that means that there have been 6,400 overdoses since 2017, so just in 4 years, that have been responded to appropriately. Looking at kind of neighborhood-wide effects, so trying to capture deaths that are being avoided even outside of the facility after people leave. Right around the Insight facility in Vancouver, they were found to have a 35% decrease in deaths, but that was during a time that there was a 10% decrease in the city overall. So imagining somewhere around a 25% decrease in deaths for the neighborhood, which is hard to imagine other interventions we've ever come up with that have that kind of effect. Seattle is starting to discuss a SIF, and the pilot projection is that it would reverse about 167 overdoses per year and prevent 6 overdose deaths per year. There is no official SIF in the US at this point, but there is one that is unsanctioned and operates in an undisclosed location. We have the first data out of it was published just last year, and it is consistent with international trends. So since 2014, when it started operating, there have been 10,000 injection events, 33 overdoses, and 0 deaths. In terms of increasing safety in other ways, other than just overdose, the education that clients receive around safe injection practices has resulted in at least a reported 75% of clients report changing their injection practices after being exposed to a SIF. And then in a kind of different realm around sexual health, once being exposed to these safe injection practices and kind of all the other things that come with a SIF, women around the Insight facility in Vancouver reported a 32% increase in condom use, and it was a similar increase for men after just 2 years of having the SIF in place. So these improvements, of course, lead to decreases in disease transmission. The best studied is HIV, through obviously shared needle use and unsafe injection practices. So over 10 years at the Vancouver SIFs, the best estimate is that they've prevented about 1,100 HIV cases, which again, just sit with that number. That's pretty incredible. Hepatitis C, there's a lot less incentive to study because it doesn't carry the same lifetime cost of treatment as HIV. But in a pilot, in a proposed pilot for Montreal, there's a prospective study that estimated that one CIF there would prevent 65 cases of hepatitis C every year. There's a lot of concern that if we make injection safer, that there will be increased injection. And it's a really important question. The majority of the evidence essentially is against the idea that making it safer increases injection drug use in this way. In the Vancouver neighborhood around the injection site, there was a retrospective study that found no increase in use following the opening of the safe injection facility. In terms of client reports, 23% said that they stopped use during the first year following the injection facility. It's a little hard to know how to interpret that without having background rates. And 53% of respondents entered treatment during that first year. Of note, that's at a facility that has on-site treatment. When they do need to refer off-site for for client preferences or whatever, there's only about a 40% follow through, but of note, 20% of respondents said that they were prohibited from entering treatment because of wait times. So I think it really speaks to the value of co-locating those services. The increased engagement with other services, this is really a little bit harder to get numbers on. We do know that one site in Switzerland reports that it sends about 3,000 referrals annually to other healthcare services. For this patient population that has a lot of needs for support services and is typically pretty poorly connected to formal services, it speaks to CIFs as being a really important touch point for these clients. How do CIFs affect really the surrounding community? So crime rates is a topic that comes up very quickly in a lot of CIF discussions. The evidence is a little bit mixed on this, but I think the best summary is that it supports no increase in crime. So when there have actually been studies of reported crime rates in Vancouver and Sydney, there was not found to be an increase. When you ask people about perceptions of crime, that's where it gets a little bit different. So at least in Sydney and in Germany and in Switzerland, there was one survey that found that local business owners reported a significant reduction in property crime rates 5 years after safe injection facilities opened. There was a big study of European sites that included 15 neighborhoods surrounding different safe injection facilities. In 9 of them, the perception was that crime had stayed the same or decreased. And in 6 of them, people perceived that crime had increased. So it doesn't seem to have a convincing effect in one direction or the other. In terms of the visibility of IV drug use, which really affects, people's experience of maneuvering a city, safe injection facilities have a really positive impact. So in terms of disposed needles that are being found, which are both a safety issue and just an aesthetic concern, there was a 42% reduction 1 year after the safe injection facility opened in Vancouver. And in terms of witnessed public injections, there was a 50% reduction. So overall, the safe injection facilities decrease deaths from overdose and all causes, decrease disease transmission, decrease risky sexual behavior, decrease isolation and alienation, both formal and informal, as I think one of the client testimonies spoke to earlier, have kind of a wash impact on crime and decrease unsafe needle disposal. So again, if you think back to a patient that you have and you look at these outcomes, I bet that they would match pretty well with what you would hope for your patient. All of this leads to the American Medical Association issuing the statement that studies from other countries have shown that supervised injection facilities reduce the number of overdose deaths, reduce transmission rates of infectious disease, and increase the number of individuals initiating treatment for substance use disorders without increasing drug trafficking or crime in the areas where the facilities are located. that's a pretty strong endorsement, reflecting kind of the global understanding of safe injection facilities at this point. So anytime that there's something that seems really evidence-based that's not being implemented, I wonder, are finances the obstacle? And when we look at the finances of safe injection facilities, Vancouver is probably the best studied. And when they look just at financial savings from lifetime HIV treatment costs that are avoided, so not taking into account emergency medical services that are avoided, not taking into account the lives saved, just on the basis of HIV, the site is easily cost effective. US sites that are starting to look at cost projections, Baltimore has a projection that says that it would save $6 million annually from one safe injection facility. For Seattle specifically, it was estimated that we would save $5.1 million annually, which would be $4.22 for every dollar spent. So of course, there's challenges with aligning revenue streams, but overall, finances are not the obstacle. Of course, safe injection facilities are not perfect. They have ongoing challenges in terms of implementation. Access hours are limited. They're typically open 12 to 16 hours a day. We know that people need to inject 24 hours a day. There can be wait times, especially around certain times of the month or certain events. There are a lot of people, and this tends to happen in the context of romantic relationships where one partner is not familiar with how to inject on their own and they rely on the other partner's help. Safe injection facilities don't allow assistance, and so it's not something that can benefit them. A lot of people use socially or pool resources and share drugs. Again, not a thing that's allowed at safe injection facilities as they typically stand. Clients report that nodding off, if that's your goal with injection, is less enjoyable. If you're being, rattled awake and checked for withdrawal. And then some clients have reported that if they develop relationships with staff and come to perceive staff as being disappointed with their continued use, that can actually serve as a barrier to them accessing safe injection facilities. But mainly in the US, the challenge is to opening them, and there are legal and political challenges that I'm about to dive into. So the global picture on this, there are 120 safe injection facilities in 10 countries. Those 10 countries are basically the usual suspects. So here's Europe. We've got Barcelona, the Netherlands, and Switzerland make up most of it. There's also sites in Australia and Canada. The legislation in the US really focuses on the federal crack house statute. So as is common in the US, there's not total agreement between local, state, and federal law on topics. And so there's a lot of question about what should be honored in discussing safe injection facilities. So the crack house statute is a law from 1986 as part of the criminalization response to the crack epidemic that essentially made it illegal to knowingly house or assist in drug consumption. And this has reigned supreme in some recent legislative setbacks for safe injection facilities. So in January of this year, Philadelphia, which has been moving along really well with safe injection facilities, their site met a significant setback in that the third district court of appeals ruled in favor of the crack house statute and against the safe injection facilities, which has put a question mark around all planned safe injection facilities. There has already been an appeal. The third district refused to rehear the case. It will probably be headed to the Supreme Court. Where I'm sure a lot of us can think of precedent from another topic area where there's been disagreement between federal and local laws, and that's really the marijuana legalization effort. And I think we can learn from that the more that we have this conversation in the context of public health, which is a state responsibility, the more leeway we give to the federal government to not enforce rules that might be on the books. And also, of course, the more we can talk about revenue, the more convincing it is. The proposed sites in the US are San Francisco, Seattle, Boston, New York, Philly, and Denver. So it has some traction. Seattle and San Francisco are saying that they're going to open their sites in 2021. Of course, remains to be seen what really ends up happening with that after the court ruling recently. In Seattle, we already have $1.4 million budgeted for it. It's actually been in the budget since 2017. Our plan recently changed from creating a new site to working with King County Department of Public Health to contract through nonprofits at locations where there's already a lot of active substance use, like emergency shelters and different healthcare facilities, to be responding to overdoses more quickly. 61% of Seattleites support it. So, big takeaways are that SIFs are very effective tools for reducing the impacts of IV drug use on patients, surrounding neighborhoods, the whole medical system. They have really favorable evidence. They mainly face political and legal obstacles to opening in the US. And because of that, physician advocacy is needed now to support these efforts and get them off the ground. Here are my references. If you're actually going to read any of them, I would really highlight the second one, Pardo. It's quick, snippy, gives you a great overview of the evidence. Thank you everybody for listening to the talk. I would love to entertain any questions. While we're doing that, I'll just highlight these QR codes. These are both for a Seattle organization called Yes to SES, Supervised Consumption Sites.org. On the left, you can sign up for their emails, and on the right, you can sign on to a letter to the mayor in support.
Okay, here's one of the questions. Is there any data on community pushback for these sites? We've had conversations numerous times in my local area, and many people are strongly opposed out of concern for increased crime and loitering.
Yeah, I don't have data on that. I have anecdotal experience with where the pushback comes from. It seems like there's a lot of concern for increased crime and things that are not evidence-based, as we discussed in this talk. My sense is that the fundamental pushback really comes from a moralizing response to it, that why should we be investing more money and more resources towards really highly stigmatized activity. I think if you just save these slides, you'll be able to have an evidence-based response to the kind of straw man arguments that I think are typically used. Great. In that case, thank you so much for listening. We're going to move on to Dr. Voltarelli, who's going to be talking to us about buprenorphine.